Okay, the first metatarsophalangeal joint.
Flex your toe downward. That's gonna be right there.
Okay, the first metatarsal bone.
Right here.
The first cuneiform bone.
Right in here.
The navicular bone.
That's this bone here.
The tarsal head.
Right here.
The calcaneus.
It's your heel bone.
The sustentacalium tali.
Right in here.
The spring ligament.
From there, it's gonna connect to the navicular bone.
The tibialis posterior tendon.
It's gonna come down through here and connect at the navicular again.
The flexor digitorum longus tendon.
Again, down through here and coming over to the second through fifth toe on the plantar side.
The flexor hallucis longus tendon.
Over here again to the big toe on the plantar side.
The medial calcaneal tubercle.
It's gonna be right in here.
The plantar fascia.
Extend your toe. It's gonna extend it if you can, upward. Right in here. This, it'll stick out right here.
The sesamoid bones.
Right in here.
The fifth metatarsal bone.
This bone of the pinky toe out here.
The cuboid bone.
Right here.
The peroneal tubercle.
That's gonna be a little hump right in here.
The peroneus brevis tendon.
That's gonna come from there and be at the shaft of the fifth metatarsal.
The peroneus longus tendon.
That's gonna come down and come up. Oh, actually, that's gonna come under to the first cuneiform and first metatarsal.
The cuneiform bones 2 and 3.
1, here's gonna be 2, and 3 is gonna be here at my thumb.
The dome of the talus.
Invert your foot, right here.
The sinus tarsi.
This depression on the lateral side, right in here.
Extensor digitorum brevis muscle.
That's gonna come and attach to the first through third toes.
The tibialis anterior tendon.
Actually, it's gonna be right in here. This one.
The extensor hallucis longus tendon.
That's gonna come over at the down below and then into the big toe here.
The extensor digitorum longus tendon.
Same as these second through fifth toes.
The peroneus tertius.
That is going to attach at the shaft of the fifth metatarsal head.
Okay, that concludes palpations.
So next I'm going to move into active range of motion. So I'm going to start with great toe extension and flexion. So I'll have the patient push down their big toe and then extend it upward. And then the same with the second through fifth, push down for flexion, up for extension, and I would have them do that bilaterally. So next I'll do goniometer measurements, have them push down to find the joint there, and then back to the neutral position and put the fulcrum on the joint. And then I'll have you flex downward. That is about at 75, and that's good. It's between 85 and 75 for normal range for flexion. And now I'm going to do extension. So there's the joint with the fulcrum there. She's in a neutral position. Now extend it up towards you. This is 45, which is in the normal range, 35 to 45. So I do those bilaterally, and then I'm going to go to passive range of motion, so stabilizing the joint here, and then I will do flexion and extension on the big toe, and I have a firm end feel, so that's good. And then I'd do that for all the toes, both sides bilaterally. And then next I'm going to do manual muscle testing. So I will have you push down on my finger with your big toe. That's good, 5 out of 5. And now extend upward. Good, 5 out of 5. Same thing for these toes, push downward, flexion, 5 out of 5, extension, 5 out of 5, comparing bilaterally for all of those as well. Moving on to a special test, I will do the valgus first. So I'm going to move the toe above, holding above the joint, moving it laterally there. Is testing the MCL, and if there's pain, that could mean MCL joint. And then varus is moving the toe medially and testing the LCL, and that could, pain with that could indicate an LCL sprain. I would do that bilaterally as well. Next, I'll do the inner metatarsal glide test. So on these heads, I will just be gliding them back and forth against each other. I would do this for all of them and compare bilaterally, and pain or increased laxity could mean a deep transverse metatarsal ligament trauma there. And then next is the tarso-metatarsal glide test, and with this I will be moving them up and down by themselves, gliding it up and down one at a time, doing that for each one and comparing bilaterally. And increased glide could mean increased ligamentous laxity, and decreased glide could mean joint adhesions. And then for the then it's mid-tarsal glide test, moving to the tarsal bones, the same thing, moving one at a time, up and down, going through them all, and then bilaterally, same thing, increased glide would mean ligamentous laxity, and decreased glide could mean joint adhesions. And then I will go into the Tinnell's test. That's tapping on the posterior tibial nerve root here, and pain or tingling or numbness with that could mean an entrapment of that nerve. And then next I will do the long bone compression test. With this, I'm going to apply axial pressure on all the toes, and same with the Tinnell's test, compare bilaterally, same with this one bilaterally, and I'm going to do all these. And the axial pressure with pain could indicate a metatarsal fracture in there. Next, I'm going to do the navicular drop test. Oh, while she's still up here, I'm going to do the interdigital neuroma test. So for that, it's just pushing the two together for a minute or two on all of them, and then that could indicate a neuroma within the toes. A common is the third and fourth toe, Morton's neuroma. Now I'll do the navicular while those are done. I will have the patient sit in the chair with both feet on the ground. I'm going to mark her navicular bone while she is non-weight bearing. Right in there. Oop, the bottom mark. I kind of got two. And then up from there, I'll mark it, and then I'll have her stand full weight bearing, and I'll mark it again. And there is a small drop, and I would measure that in millimeters, and if it's over 10 millimeters, that's hyperpronation of the foot. Next, I'm going to move into neurovascular testing. I'm going to first find the dorsal pedis pulse, which is in between the first and second toes on the dorsum side. And right there it is. And then the next one is the posterior tibial pulse. And there it is. The next, I'm going to do the myotomes and dermatomes, starting with the L4 dermatome testing on the great toe. I'm going to just ask my patient sharp or dull as her eyes are closed, and she's going to tell me what pain she feels. So sharp, dull, sharp, tall. She'd try to distinguish each. That's for the L4 dermatome, and myotome for that is ankle dorsiflexion. So I'm going to have her bring her foot upward. And then next is the L5, and that's like the web space here between the first and second. So sharp, dull, same thing. She'd tell me the difference. Her eyes are closed. And then big toe extension, so bring your big toe up, is the myotome for that, L5. And then next is S1, and the dermatome is the peroneal region. So sharp, dull, she would tell me there. And then the myotome for that one is going to be plantar flexion, so push down the gas pedal. Lastly is S2, and the dermatome is the plantar side of the heel, so sharp, dull, same thing. And then the myotome is knee flexion, and I would have her bring her knee up or lay on her stomach and bring it up, either way. So next, I would do that all bilaterally. Next, I'm going to have my patient have her leg off the table, and I'm going to do the quadricep reflex test, tapping on the patella on the L4 nerve root. There, we get a kick. And if both sides don't fire, that could be an upper neuroma lesion, and if only unilaterally one side doesn't fire, that could be a lower motor neuron lesion. And then next I'm going to do the same for the Achilles, and that's the S1 nerve root. So there's just a little bit of movement there. That was more real. Same thing there. If both don't file bilaterally, it's going to be an upper motor neuron lesion, and then if unilaterally, it could be a lower motor neuron lesion. That's all. Thank you.